Have you ever wondered what truly goes on behind those swinging doors in the emergency department? What are the unwritten rules, the high-stakes decisions, and the hidden challenges that medical professionals face every single day? It's a place of intense pressure, critical decisions, and often life-altering moments, all playing out in real time. Today, we're taking a deep dive into the very core of emergency medicine, our mission, to uncover the fundamental principles, surprising realities, and the incredible human element at play in one of healthcare's most dynamic environments. We're drawing our insights directly from a pretty definitive source, the Oxford Handbook of Emergency Medicine. This isn't just a casual look, it's a curated journey through an expert guide's perspective on the field, offering you a shortcut to being well-informed. You'll gain, hopefully, a deeper understanding not just of the what, but the why of emergency care. So let's get started. Okay, let's unpack this. Imagine a set of golden rules that guide emergency medical professionals. These aren't just suggestions. They're foundational principles that, if broken, require very careful consideration. What I found particularly fascinating here is how they blend the intensely practical with, well, profound wisdom, almost like life lessons.
That's a great way to put it. These golden rules aren't just medical guidelines. They're truly a framework for high-stakes environments, serving as the bedrock upon which safe and effective patient care is built in the fast-paced, often chaotic world of the emergency department. You know?
Makes sense. So where do we start? What's rule number one?
One of the foremost of these rules, and perhaps the most universal, is always listen to nagging doubts. This isn't about second-guessing yourself to the point of inaction, but rather about cultivating a vital sense of intuition and vigilance. In emergency medicine, where a patient's symptoms can be ambiguous and their condition can deteriorate rapidly, that subtle feeling that something is off, well, it's a critical safety mechanism. It should prompt you to delve deeper, perhaps order additional investigations, or, crucially, seek senior consultation. Recognizing and acting on that internal red flag can literally mean the difference between life and death. It's a profound insight, really, that doubt isn't a weakness, but a powerful early warning system applicable far beyond the ED.
That makes so much sense, not just for doctors, but for anyone making critical decisions. It's about respecting your gut feeling, but also knowing what to do with that intuition. And that actually ties right into the next rule, doesn't it? Do not work beyond your expertise. Seek senior advice. How do these two seemingly contradictory ideas, trusting your gut versus knowing your limits, actually work together in practice?
That's an astute observation.
Yeah?
They're complementary. Your nagging doubt often tells you when you're approaching the edge of your expertise. This rule then underscores a profound culture of humility and continuous learning. No single individual can know everything, especially in a field as broad and complex as emergency medicine. Knowing your limits and having the self-awareness to recognize when a case surpasses your current expertise is not a sign of weakness, but of immense strength and professionalism.
Right.
Patient safety always comes first, right?
Right. Safety first.
And seeking timely senior advice ensures that the patient receives the highest level of care available. It also fosters a collaborative environment where knowledge is shared and junior staff can learn from experienced colleagues, reinforcing that collective intelligence is paramount.
So it's about building that safety net through teamwork.
Precisely. And following directly from that, if someone does give you advice, the rule is to record advice and who gave it. This is critical for accountability and clear communication. In the rapid flow of an ED with multiple patients and staff members, precise documentation of who said what and when is indispensable for continuity of care and for medical legal reasons later on. It creates an undeniable paper trail.
Okay, accountability. That brings us to another seemingly simple but incredibly important rule. Referral means referral. It sounds obvious, but I imagine there's a hidden depth to that seemingly straightforward statement.
There is. A referral, once initiated, is essentially a one-way process in terms of responsibility for that aspect of the patient's care. It signifies a clear, unambiguous handover of responsibility to another team or specialty for a specific issue or for ongoing management. It's vital for maintaining clarity in the patient's care pathway and ensuring that the referred issue is definitively addressed, rather than falling through the cracks or being reevaluated unnecessarily by the referring team.
Like passing the baton in a relay race.
Exactly like that. Once it's passed, that segment is now someone else's responsibility to carry forward. It ensures seamless continuity of care and avoids dangerous ambiguity.
Got it. And then notes. Clear notes.
Yes. And then, when it comes to notes, we have legible notes. Always record explanation and advice given. This transitions us directly into the medical legal imperative of ED practice. The importance of clear, legible documentation cannot be overstated. It's not just about what you do, but proving that you did it correctly and responsibly. Every single piece of advice given, every explanation to a patient or relative needs to be recorded. This is crucial both for patient understanding and for protecting the clinician down the line. It's the ultimate what isn't documented didn't happen principle at work.
What I've found particularly eye-opening here, and I think our listeners will too, is just how far-reaching the impact of good documentation is. I mean, in an environment where hundreds of patients are treated monthly, how do you keep track? It turns out notes aren't just for current care. They can be the prime source of evidence years later, even in negligence cases.
This is absolutely foundational for emergency medicine. Clinicians treat hundreds, maybe thousands of patients every month, and it's simply impossible to remember all the specifics of each case years down the line. This is why the emergency department record becomes the prime source of evidence in potential negligence cases. If notes are deficient or missing, it can become incredibly difficult, if not impossible, to defend a claim, even if no actual negligence occurred. This is a crucial point for all practitioners to understand. The quality of your notes directly impacts your medical legal standing. It's the power of the written word and its long-term consequence.
Wow. So the notes aren't just a record, they're potentially a legal defense.
Precisely. Furthermore, patients have a right of access to their medical notes under Data Protection and Access to Medical Records Acts. This means that anything you write can, and potentially will, be read by the patient in the future. This fact should influence how documentation is approached, encouraging clear, unambiguous, and non-judgmental language. It emphasizes transparency and professionalism in every entry, knowing your words are not just for colleagues, but for the patient themselves.
So it's not just what you write, but how you write it, knowing it might be scrutinized or reviewed by the patient themselves. What are some of those specific documentation rules that are so vital for maintaining such high standards?
There are several specific documentation rules that are paramount for accurate and defensible records. Firstly, regarding the presenting complaint, you must clearly indicate from whom the history has been obtained, whether it's the patient themselves, a relative, or a paramedic. And importantly, avoid attributing events pejoratively, for example, saying, the patient was struck by Joe Blogs when it's simply a statement from a third party. Stick to the facts as presented, just report what was said.
All right, keep it objective.
Exactly. For previous relevant history, it's crucial to note any recent ED attendances. Also, check the hospital's electronic records system for other pertinent information, such as recent letters and investigation results. Comparing against previous ECGs, for instance, can be incredibly useful for heart-related issues. A detailed social history is also essential, particularly when there are potential concerns about the safety of discharging the patient later. This could include aspects like their living situation, their support network, or if they live alone, things like that.
Discharge planning starts early then.
It has to. Then when it comes to advice given, you must always record what explanation and advice you provided, to whom you gave it. For example, the patient, a family member, and if referring or handing over a patient, the time of referral or handover, along with the name, grade, and specialty of the receiving doctor. This ensures a clear audit trail and responsibility. Informing the patient's general practitioner by letter or email, even if the patient is admitted, is also standard practice, with computerized systems often generating these letters. In complex cases, sending a copy of the ED notes with investigation results, and even considering giving a copy to the patient, can be beneficial for their understanding and continuity of care.
What about things like checklists or templates? Do they use those?
Yes, we also use proformas increasingly, especially with the emphasis on evidence-based guidelines. These are standardized forms or checklists, a bit like a pre-filled template, which aim to ensure every patient gets a comprehensive assessment. While these have advantages in guiding comprehensive assessment and ensuring no critical steps are missed, it's important to bear in mind that for some complex patients, simply completing a proforma may not adequately capture all the necessary, nuanced information. There's a balance between efficiency and thoroughness.
So templates help, but don't replace good clinical notes.
Exactly. Lastly, a critical general rule for documentation is avoiding abbreviations and ensuring clarity. Abbreviations, while common in quick notes, carry a significant risk of confusion and misinterpretation, which can have serious consequences. It's always safer to write things out in full, especially specific anatomical details like right index finger instead of just RIF, rather than relying on potentially ambiguous shorthand. Good notes imply good practice, and meticulous, legible, and comprehensive contemporaneous notes are the foundation of a successful defense in any potential medical negligence claim.
So it's clear that the written word is paramount, But let's shift from the documents to the people themselves. What's it actually like to be in that environment day in and day out? What does this all mean for the people who work in the ED? It's not just about medical knowledge. It's about a unique culture of teamwork, resilience, and facing immense pressure. It truly paints a picture of life on the front lines.
It absolutely does. The emergency department is characterized by its unique team-based approach, often described as a functional family due to the intense situations they face together. The ED team is incredibly diverse, comprising nurses including nurse practitioners, nurse consultants, and healthcare assistants, along with advanced care practitioners, permanent and fixed-term doctors, reception and administrative staff, radiographers, and other specialists like psychiatric liaison nurses or plaster technicians. A key feature is how traditional roles are often blurred. The important issue isn't a rigid job description, but rather what clinical skills a member of staff is capable of. This flexibility is vital in such a dynamic, unpredictable environment.
So it's more about capability than title?
Pretty much. Despite this teamwork, the reality of overcrowding is a constant, unavoidable challenge. It inevitably and adversely affects patient privacy and dignity. You might regrettably see patients waiting on trolleys and corridors as capacity becomes saturated. Many EDs have recognized that it can actually be safer for selected patients to wait in a queue for a bed than for unselected patients to wait to get in, highlighting the difficult choices made in real time. While a limited assessment might be necessary in a corridor, it's a strict rule to never undress patients for examination in such a public area, as patient dignity must always be paramount.
That sounds incredibly challenging. How do they maintain patient safety and dignity with such an intense environment and so many people waiting? There must be some practical measures in place to mitigate those risks.
There are. Many EDs implement a patient safety checklist for an overcrowded department to combat these risks. This includes providing reassurance to patients arriving to a crowded ED, explaining that while the environment isn't ideal, their care is still a priority, and using a private area if requested by the patient. Crucially, a private area must always be used for any examination or investigation where the patient needs to get undressed, such as a chest or abdominal examination or recording an ECG. Clinicians are also required to document clearly in the notes any examinations that are suboptimal due to the inability to adequately assess patients in the corridor, with a commitment to complete the examination fully at the earliest opportunity.
Documenting the limitations, okay.
Yes. And finally, and perhaps most importantly, ensuring routine nursing and clinical care, including analgesia, medication, regular observations of vital signs, assistance with toileting, food, and drink, continues wherever the patient is located, with staff keeping patients informed about their progress. Basic care doesn't stop.
What about the staff themselves, especially junior doctors? The pressure must be immense.
Oh, absolutely. Then there's the significant aspect of coping as a junior doctor. The physical demands are substantial, often involving long shifts and high intensity. While active young doctors can often cope, a demanding professional life and a demanding social life are rarely compatible. The handbook explicitly states tired doctors make mistakes. They also tend to have less patience, which can lead to interpersonal conflicts. But beyond the physical, the mental aspect of the job is often a greater problem. For many, the ED is the first time in their careers they have to make unequivocal decisions based on their own assessment and investigations, without immediate supervision for every step. This is simultaneously one of the greatest challenges and excitements of emergency medicine, but also a significant source of worry. The process of decision-making does become easier with experience, and developing a structured approach can preempt many problems.
It sounds like an incredibly high-pressure environment where resilience is absolutely key. But what happens if that pressure becomes too much? What's the advice when you feel like you just can't cope? Because that must happen to anyone under such strain.
That's a critical point, and the advice is unequivocal. If you can't cope, tell someone. The handbook strongly emphasizes, do not bottle it up, try to ignore it, or assume that it reflects inadequacy. It does not. Everyone, at some time, has feelings of inability to cope. Trying to disguise or deny the situation is unfair to oneself, colleagues, and patients. The clear instruction is to talk to a consultant, or if that feels too daunting, a general practitioner or another senior member of staff. It highlights the importance of open communication and seeking support within what is known to be a considerable degree of camaraderie within the ED team, largely due to the intense nature of the job, the types of patients encountered, and the diversity of staff involved. Junior medical staff often work for shorter periods, while other staff may have spent a lifetime there, fostering a unique dynamic where experience is highly valued and shared. Junior staff are encouraged to respect the position and experience of others and learn from them.
That camaraderie sounds essential. What about the link with the ambulance crews? They're the first point of contact often.
Absolutely. Another crucial professional relationship is liaising with ambulance crew. Paramedics and ED staff have a very close professional relationship, working in conditions that are often difficult and sometimes dangerous outside the hospital. The handbook even suggests that it's worth taking an off-duty day to accompany a crew during their shift to truly understand the problems they face, fostering mutual respect.
Really, go out on a shift with them.
Yeah, it gives you incredible perspective. In the UK, a patient brought by ambulance will routinely have a patient report form, PRF, completed at the scene and in transit. The information on these forms is invaluable, particularly the time intervals between the 999 emergency call, arrival at the scene, and arrival at the hospital, which provide a critical time framework for interpreting changes in the patient's clinical condition over the transport journey.
Right, those timings must be crucial for understanding how things have developed. Okay, let's move on to the core mission. When a patient arrives in the ED, there's a clear hierarchy of what needs to happen first. It's not a free-for-all. It's a highly structured approach to saving lives. It sounds like they have a very precise step-by-step method.
They do, and it's meticulously structured. The ED operates on a set of clearly defined priorities, almost like a medical triage system in action. The very first and most critical priority is to make life-saving interventions. This means addressing immediate threats to life, such as airway obstruction, severe bleeding, or cardiac arrest, before anything else, because without these, nothing else matters.
Stop the dying first.
Essentially, yes.
Right.
Once these immediate threats are addressed, the next priority is to provide analgesia. This isn't merely about patient comfort, though that's important. Effective pain management can also improve patient outcomes, reduce stress, and facilitate further, more accurate assessment.
Pain relief is high up the list then.
It really is. Following that, the focus shifts to identify relevant issues, investigations, and commence treatment. This involves a comprehensive assessment, ordering necessary diagnostic tests like X-rays or blood work, and initiating specific treatments for the patient's condition based on the findings. Finally, the last priority is to decide upon the need for admission or discharge. This involves a thorough evaluation to determine whether the patient requires inpatient hospital care for ongoing treatment and monitoring, or if they can be safely discharged home with appropriate follow-up instructions and support. This structured approach ensures that the most critical needs are met first, optimizing patient outcomes in a systematic way.
Okay, that makes sense. ABCs first, then pain, then figure out the problem, then decide where they go next. Now, these are moments where seconds truly count. Let's delve into two critical situations where immediate, decisive action can be the difference between life and death: anaphylaxis and cardiac arrest. They represent the ultimate tests of rapid response.
These are indeed two of the most time-critical emergencies encountered in the ED, demanding swift and accurate responses. Starting with anaphylaxis, it's defined as a severe, life-threatening, generalized allergic reaction of sudden onset, developing rapidly after exposure to a foreign substance. The mechanism typically involves an IgE-mediated reaction, meaning your body's immune system, specifically a type of antibody called IgE, overreacts dramatically to a normally harmless substance. Common triggers include insect stings, certain foods like peanuts or shellfish, or medications like antibiotics, to which the patient has previously been exposed.
So the immune system goes into overdrive.
Exactly. The clinical features of anaphylaxis are categorized by severity across three main systems: the airway, breathing, and circulation. For airway obstruction, you'd look for signs like an effective or ineffective cough, hoarseness, or noisy breathing. Breathing problems manifest as bronchospasm, which is a tightening of the airways, making it hard to breathe, or cyanosis, a bluish discoloration of the skin due to lack of oxygen. Circulatory issues include hypertension, dangerously low blood pressure, and tachycardia, a very fast heart rate. Recognizing these signs quickly is paramount.
Airway, breathing, circulation.
Yeah.
The ABCs again.
Always. The treatment is immediate and decisive. The primary intervention is intramuscular, IM, adrenaline, injected directly into the muscle. For adults, the dose is typically 0.5 milligrams of a 1 in 1,000 solution, given into the anterolateral thigh, the outer part of your upper leg. This can be repeated every 5 minutes if there's no improvement. For children, the dose varies carefully by age and weight. For instance, 120 micrograms for infants to 6 years, 250 micrograms for 6-12 years, and 500 micrograms for children over 12, also IM. Importantly, subcutaneous SC adrenaline, injected just under the skin, has absolutely no role in anaphylaxis because its absorption is far too slow compared to IM, delaying vital treatment.
So I am adrenaline fast. What else?
Beyond adrenaline, if hypotension doesn't rapidly respond, IV fluids given directly into a vein are crucial. A rapid infusion of 1 to 2 liters of 0.9% saline, which is a sterile saltwater solution, may be required for adults, with further infusion guided by the patient's clinical state. For bronchospasm, a U2 agonist like salbutamol, which works by opening up the airways, can be nebulized with oxygen, possibly with the addition of nebulized ipratropium bromide. Antihistamines, such as chlorphenamine given slowly into a vein, and H2 blockers like ranitidine 3, are commonly given as second-line drugs. They, along with hydrocortisone slow-feely, may help reduce the severity and duration of symptoms, though adrenaline remains the first line. For severe anaphylaxis, mast cell tryptase testing can be considered at baseline and then ideally within 1 to 2 hours and no later than 4 hours after treatment starts to confirm the diagnosis.
Right, a blood test to confirm later.
Yeah.
Okay, from anaphylaxis, where a rapid immune response can shut down the body, we move to perhaps the ultimate medical emergency, cardiac arrest. This is where every second truly counts, isn't it? How does an ED team recognize and immediately respond when a heart stops?
This is indeed the apex of emergency medicine. Cardiac arrest is a clinical diagnosis. You suspect it in any patient who is unconscious and has no normal breathing. The response is governed by a strict, internationally recognized resuscitation algorithm, such as those provided by the Resuscitation Council UK. This algorithm provides a structured, step-by-step approach to maximize chances of survival.
A clear protocol is vital.
Absolutely. The cornerstone of resuscitation is immediate, high-quality chest compressions. These must be delivered with minimal pauses at a rate of 120 compressions per minute and a depth of 5-6 centimeters for adults, about 2 inches. For infants, both thumbs side by side on the lower third of the sternum, pressing down at least 1/3 of the depth of the chest, or approximately 4 centimeters. Minimizing interruptions to compressions is vital to maintaining blood flow to the brain and heart. The handbook even emphasizes the visual of correct compression technique, reinforcing its critical importance.
Push hard, push fast, don't stop.
That's the mantra. Defibrillation is also incredibly time-sensitive. Most survivors of cardiac arrest have an initial heart rhythm of ventricular fibrillation, VF, or pulseless ventricular tachycardia, VT. Both of these are chaotic electrical activities in the heart that prevent it from pumping blood effectively. The treatment for this is defibrillation, which delivers an electric shock to reset the heart's rhythm. The chances of successful defibrillation and survival decrease dramatically with every passing minute. Adhesive defibrillator pads have largely replaced manual paddles in hospitals, making the process quicker and safer. One pad is placed to the right of the upper sternum, just below the collarbone, and the other at the mid-axillary line around the side of the chest level with the armpit. In monitored patients with pulseless VFVT where immediate defibrillation isn't available, a single precordial thump can be considered. A direct, sharp blow with a tightly clenched fist from a height of 20-30 centimeters to the lower half of the sternum as a last resort before defibrillator is ready.
A thump. Does that actually work?
Sometimes, in very specific monitored situations, but defibrillation is the key. Airway management is another critical component. While tracheal intubation, inserting a tube into the windpipe, has long been considered the gold standard for a definitive airway, it should only be attempted by suitably experienced personnel. A supraglottic airway, which sits above the voice box, is a readily available, rapid alternative that is generally easier and quicker to insert. Whatever method is used, the aim is to ventilate the patient, preferably with 100% oxygen, to ensure their body is receiving vital oxygen.
Get oxygen in one way or another.
Right. And then post-resuscitation care is crucial for optimizing outcomes once a patient's heart has restarted. This involves obtaining a 12-lead ECG, an electrocardiogram, to check for underlying heart conditions, and a chest X-ray to check the position of any inserted tubes and lines, and to rule out a pneumothorax, which is a collapsed lung. Optimizing cardiac output with medications called inotropes or vasodilators, fluids, or diuretics may be needed under hemodynamic monitoring, which constantly tracks blood flow. If the arrest was associated with an acute coronary syndrome like a heart attack, immediate thrombolysis, clot-busting medication, or coronary revascularization, which is restoring blood flow to the heart, should be considered.
So getting the heart started is just the beginning.
It is. For venous access, getting fluids and medications into the bloodstream quickly, the external jugular vein in the neck is often readily visible and easily cannulated with a standard IV cannula, making it a good initial option in an emergency. For central venous access, which provides a more reliable and long-term route, the internal jugular and subclavian veins are typically used. Subclavian vein cannulation below the collarbone carries a relatively higher risk of pneumothorax, so the internal jugular vein is usually preferred via a high approach in the neck. ideally with ultrasound USS guidance to visualize the vein and avoid complications. If a chest drain is already in place for a collapsed lung, it's generally recommended to use the same side for central venous cannulation to avoid creating a new pneumothorax on the unaffected side.
Okay, lots of technical details there for getting access. Now, beyond the dramatic cardiac arrest, there's a constant vigilance in the ED for subtle signs of serious illness. How do professionals spot conditions where urgent intervention is needed, even before a full collapse? It's like an early warning system.
This brings us to the crucial concept of recognizing the sick patient and identifying time-critical illnesses. These are conditions where urgent intervention is required to secure the best outcome for the patient, as delays can lead to rapid deterioration or even death. Examples include sepsis, a life-threatening response to infection, myocardial infarction, MI, or a heart attack, major trauma, a ruptured abdominal aortic aneurysm, a dangerous tear in the body's main artery, and a ruptured ectopic pregnancy, a life-threatening pregnancy complication. The clinical diagnosis of some of these conditions is not always straightforward at first glance.
So spotting the subtle signs is key.
It is. However, a common theme across many of these time-critical illnesses is that they present with deranged physiology and vital signs. This is where early warning scores become invaluable. These systems are implemented upon a patient's arrival at the hospital to help systematically identify seriously ill patients who might otherwise be overlooked. They standardize the assessment of vital signs like heart rate, blood pressure, respiratory rate, and temperature, and trigger alerts when readings fall outside normal parameters, prompting a rapid clinical review.
Like a structured way to check if something's seriously wrong.
Exactly. To illustrate this, let's take the example of neutropenic sepsis. This is a life-threatening infection in patients with very low levels of neutrophils, a type of white blood cell usually due to chemotherapy. If a patient presents with a fever or unwell with symptoms and signs of clinically significant sepsis and has a neutrophil count of less than 0.5 by 109 L, treatment should be started immediately. The critical directive here is do not delay the administration of intravenous antibiotics whilst waiting for the neutrophil count to be processed by the lab. If in doubt, especially for a patient who has recently received chemotherapy, it's assumed they are likely to be neutropenic. The sepsis bundle, which includes giving broad-spectrum antibiotics according to the local protocols, for example, piperacillin, tazobactam fifth, or ceftazidime if penicillin allergic, is then immediately initiated. This proactive, swift response, based on clinical suspicion and vital signs, can be life-saving. It's about recognizing the early whispers of a severe problem.
Treat first, confirm later if it's sepsis. Got it. Now let's talk about something almost every patient experiences, pain. Pain is often the first thing a patient feels in an emergency, and managing it isn't just about comfort, it's a key part of the healing process in preventing further harm. How do emergency professionals approach such a subjective but critical aspect of care?
That's absolutely correct. Understanding and managing pain is a critical priority in the emergency department, not just for patient comfort, but because uncontrolled pain can hinder assessment, prolong recovery, and even exacerbate underlying conditions. First, assessing pain can be challenging due to its inherent subjectivity. Patients have different thresholds and ways of expressing pain, and various pain scales exist to help quantify it. Cultural and social factors can also influence how pain is communicated. Furthermore, assessing pain in children and the elderly requires particular attention, as their ability to communicate or tolerate pain may differ significantly, requiring careful observation. Therefore, repeated assessments are crucial to ensure effective and ongoing pain relief.
So keep asking, keep checking.
Exactly. When it comes to options for relieving pain, there's a wide spectrum of choices. Oral analgesia, like paracetamol or non-steroidal anti-inflammatory drugs, in SAIDs, might be suitable for less severe pain. For more significant pain, IV analgesia is often preferred for its rapid onset and titratability, meaning the dose can be carefully adjusted to the patient's need. Morphine is a common choice, administered titrated, often with an antiemetic to combat potential nausea.
Morphine is still a mainstay then.
It is, used carefully. Nerve blocks are another incredibly useful tool, especially for localized severe pain, providing targeted and often profound relief without systemic side effects. For example, a femoral nerve block is particularly effective for a fractured femur, especially in head injury patients, as it can reduce the need for systemic opioids, which might depress consciousness or breathing. Digital nerve blocks are used for finger injuries, allowing for examination and repair with minimal discomfort. Local anesthetic drugs used for these blocks include lidocaine, bupivacaine, and prilocaine, each with different durations of action and potential risks, such as cardiotoxicity or methemoglobinemia, a rare but serious side effect where your blood can't carry oxygen effectively, particularly with high doses of prilocaine.
Blocks sound really effective for specific injuries. What about gas and air?
Ah, Entonox, often called gas and air, is another popular option. It's a mixture of 50% nitrous oxide and 50% oxygen, providing rapid pain relief, usually within seconds, and its effects wear off quickly. It's particularly useful during transport and initial assessment. However, it has specific contraindications, situations where it shouldn't be used, such as undrained pneumothorax, a collapsed lung due to the risk of producing a tension pneumothorax, where air gets trapped and causes severe pressure. After diving, increased risk of decompression sickness, severe facial injury, base of skull fracture, intestinal obstruction, and decreased conscious level, as it diffuses more rapidly than nitrogen and can expand gas-filled spaces in the body.
So not for everyone. Any other key pain relief options?
Finally, ketamine has a significant role, especially in pre-hospital settings and when opioids are a concern due to their respiratory depressant effects or potential to obscure neurological signs. It offers potent analgesia and sedation with less respiratory depression than opioids, making it valuable in specific trauma scenarios.
So beyond a simple shot, local anesthesia requires a nuanced approach, especially given the various risks involved. What should we understand about how it's used and managed in the ED?
Indeed. Local anesthesia, LA, is incredibly versatile, indicated in almost any situation where it provides satisfactory pain relief or safe conditions for procedures. This includes a wide range of common ED procedures, from inserting venous cannulae, 5E lines, to complex wound repair and minor surgery. However, its use isn't without risk.
Right, you mentioned toxicity earlier.
Exactly. Toxicity management for local anesthetics is critical. If signs of LA toxicity occur, such as central nervous system effects like convulsions or ringing in the ears, or cardiovascular effects like a very slow heart rate, bradycardia, or dangerously low blood pressure, hypotension, the immediate steps are stop the procedure, call for help, clear and maintain the patient's airway, give 100% oxygen, ensure adequate lung ventilation, obtain reliable IV access, monitor ECG, and record vital signs. If convulsions occur, ensure oxygenation and give a sedative medication like lorazepam. For bradycardia or hypotension, atropine and IV fluids are used. In severe cases, particularly with cardiac arrest or arrhythmias that don't respond to treatment, the use of intralipid, a special lipid emulsion therapy, is a crucial intervention, as it acts as a lipid sink to draw the local anesthetic away from vital organs like the heart and brain.
Intralipid, like a specific antidote for LA toxicity.
Sort of, yes. It helps mop it up. One specific application of local anesthesia is Beer's block, also known as intravenous regional anesthesia, IVRA. This is often used for anesthesia for the reduction of collis fractures, which are common wrist fractures, or for minor surgery below the elbow. This technique involves using a large dose of local anesthetic in an exsanguinated limb, meaning the blood has been squeezed out, isolated by a double tourniquet, like a blood pressure cuff. This poses a significant risk of toxic reaction if the tourniquet fails or is released prematurely, allowing the large dose of LA to enter the general circulation. It requires careful preoperative assessment, written consent, and at least 2 trained staff present, competent to deal with severe toxic reactions. The proximal tourniquet cuff must remain inflated for at least 20 minutes to prevent systemic absorption of the LA, but no longer than 45 minutes to avoid ischemic damage, which is tissue damage due to lack of blood flow. If a second manipulation is needed after 20 minutes and pain from the cuff is severe, the distal cuff can be inflated over the anesthetized skin before deflating the proximal cuff. This minimizes patient discomfort while maintaining the block.
Wow, that sounds quite involved and needs careful handling. Okay, let's talk about different patient groups. Every patient is an individual, but some groups present with additional needs that require a tailored approach. It's not about special treatment, but about ensuring equitable and effective care. How does the ED navigate these unique patient journeys?
That's a vital distinction. While the ideal is that every patient receives the best possible care, certain groups do have additional needs that require specific consideration for effective communication and clinical management, ensuring their unique circumstances don't hinder their care.
Like who, for example?
Well, for instance, there's been a shift in terminology from inappropriate attendance to primary care patients. It's acknowledged that coming to an ED simply due to difficulty accessing primary care is not ideal, but the term inappropriate attendance is pejorative and unhelpful. Most departments now address this by having general practitioners, GPs, work alongside ED staff, either within the department or in an adjacent unit, to manage primary care problems more effectively, ensuring patients get the right care in the right place.
So integrating primary care into the ED setting.
Exactly. Another challenging group involves patients with medically unexplained symptoms. These patients often present with ongoing problems that have been extensively investigated and no clear physical cause has been found. It can be difficult to manage them, especially because a small proportion may have an underlying treatable condition that's been missed. Information from previous attendances is extremely helpful. It's crucial to acknowledge to the patient that their symptoms are real and distressing, and to involve a senior ED clinician for review. Often the best approach is to focus on managing the symptoms and providing support, rather than trying to make a new diagnosis from scratch during an emergency visit.
Acknowledge the symptoms, manage them, but avoid endless reinvestigation in the ED.
Generally, yes. Beyond these, there are several specific patient groups with additional needs. While children are often considered a separate category, which we'll discuss next, elderly, frail patients present with unique challenges. Their presentations can be non-specific, meaning common illnesses might show up differently, such as falls, immobility, delirium, acute confusion, incontinence, or new medication issues. They often have multiple pre-existing health problems and atypical symptoms, making them more vulnerable. Key risk indicators for safe discharge include recent changes in circumstances, recent bereavement, increased confusion, or unusual behavior. Factors like inability to afford adequate food or heating or unacknowledged support needs from community services also require consideration for safe discharge, ensuring they have the necessary support once they leave the ED.
The social context is crucial for older patients.
Absolutely. Communication difficulties are also prevalent in the ED. This can range from language barriers requiring the use of professional interpreters rather than relying on family members, to patients with certain cultural or religious beliefs that can significantly impact various situations, such as decisions after unsuccessful resuscitation or modesty during examinations. Patients without social support, like the homeless or holidaymakers, also require special consideration as they may lack a network to help them with follow-up care. There are tremendous resources available like communicationpeople.co.uk that can help practitioners overcome these barriers.
And patients with learning disabilities.
Yes, for patients with learning disabilities, effective communication requires patience and specific techniques. It's important to explain the consultation process clearly before starting. Speak first to the patient themselves, then to their carer, and use open questions, then rephrase them to check comprehension. Language should be adapted to what the patient understands, using simple words and concepts. They may have difficulties with time, so try to relate symptoms to real-life temporal events like, did the pain start before lunch, rather than asking for specific times. Also, they may not connect an action they've taken with feeling ill, so multiple questions may be required to establish facts, such as whether they've ingested something. Patience and clarity are key.
In the critical moments of an emergency, a huge decision often looms, whether or not to start CPR or cardiopulmonary resuscitation. What's the protocol there, and how are those incredibly sensitive conversations handled, especially when breaking bad news?
Decisions about CPR are indeed among the most sensitive and ethically complex in emergency medicine. The default position when there is insufficient information available in an emergency is to start CPR. This is because the immediate priority is to preserve life. However, wherever possible, the aim is to make a considered decision about whether or not to initiate CPR. This should ideally involve discussion with a senior doctor, the patient themselves if they have the mental capacity to understand and decide, and their family. This decision and the rationale behind it must be thoroughly documented on an appropriate form, often now called a treatment escalation plan, TEP, which has replaced older forms like do not attempt CPR, DNA CPR, or allow natural death order, to reflect a broader discussion about overall care goals.
Treatment escalation plan. That sounds more holistic.
It is. It frames it as part of overall planning. When it comes to breaking bad news, irrespective of who performs this task, several critical points must be remembered for a sensitive and compassionate approach. Firstly, if you are informing relatives, ensure a link nurse, a dedicated support person, is with you. Take a minute or two to prepare yourself after leaving the resuscitation room, checking for blood stains on clothing to maintain professionalism. Confirm you know the patient's name and enter the room. Introduce yourself clearly and sit or kneel to be at their physical level. Ensure you're speaking with the correct relatives and identify who is who in the group. Speak slowly, keep sentences short and non-technical, and do not hedge around the subject or use euphemisms. Be direct, but gentle.
Trope but gentle. That's a hard balance.
It is. In their emotional turmoil, relatives often misconstrue information, so you may need to re-emphasize important aspects clearly and repeatedly. It's also immensely rewarding for both relatives and patients to allow the relatives to see the patient briefly, even for a few seconds after death. The link nurse can guide them beforehand about any injuries, particularly to the face or the presence of monitors, drips, and equipment, to diminish any threatening visual impact and prepare them for what they will see. Finally, when death occurs, involving religious leaders as early as possible can be invaluable for spiritual support, and the hospital chaplain should be informed to provide help to both relatives and staff who also go through emotional strain.
Supporting the family and the staff, too.
Great.
Now let's turn to children. It's a phrase you hear often in emergency medicine. Children are not little adults. It's a statement that seems intuitive, but the handbook reveals just how profoundly true it is, doesn't it? What are the most striking differences we need to understand when it comes to pediatric emergencies?
That phrase is indeed a cornerstone of pediatric emergency medicine, and it truly encapsulates the unique aspects of pediatric emergency care. Children are distinct from adults anatomically, physiologically, and emotionally, and in the spectrum of pathological conditions they are susceptible to. For staff less accustomed to children, assessing a seriously unwell child can be daunting, but experienced staff are adept at recognizing these critical signs, and their guidance is invaluable.
So what are some key differences?
Delving into those anatomical and physiological differences. In infants, unfused sutures in the skull allow the intracranial volume to increase with intracranial hemorrhage, or bleeding inside the skull. This means relatively large bleeds can occur without immediate, obvious signs of pressure, potentially leading to shock. Similarly, scalp wounds in infants and young children can bleed profusely because their blood volume is so much smaller, also resulting in significant hypovolemia or low blood volume. Their smaller airways are more easily obstructed, their higher metabolic rates mean they burn through energy faster, and their different bone structures all mean that assessment and management must be tailored specifically for them.
Bleeding from a scalp wound can cause shock in an infant.
Wow. It absolutely can. Interacting with parents is a crucial part of pediatric care. Parents are, understandably, often very worried and upset, which can make communication challenging. Taking the time to explain what is happening to their children at all stages is paramount. While appropriate consent must be obtained, life-saving measures should not be delayed waiting for consent if the child's life is at immediate risk. Allowing parents to remain with their children as much as possible, even during resuscitation, is important for both parents and children, provided an experienced nurse can support and explain what is happening. If their presence impedes resuscitation, they may be gently asked to step outside.
Letting parents stay, that must be reassuring for everyone.
It often is. When it comes to pain assessment and analgesia in children, adequate pain relief is just as important for children as for adults, despite physiological differences. Reassurance is a key component, but it's vital, to be honest. Never tell a child that a painful procedure won't hurt, as this will simply cause them to lose confidence and trust in the ED team. Instead, explain calmly what will happen and how it might feel.
Honesty builds trust, even when it's difficult. Okay, for the injured child, the resuscitation priorities remain the same: airway, breathing, circulation, but the approach must be adapted. How does the ED team manage resuscitation for a child in critical condition, especially when seconds count?
For the resuscitation of the injured child, the fundamental priorities, ABCs, remain the same as for adults, but the practical application differs significantly due to their size. Equipment sizes and drug doses differ dramatically. Establishing or accurately estimating the child's weight is crucial for accurate dosing, as a tiny miscalculation can have huge consequences. Senior ED doctors, pediatric intensive care unit, PICU doctors, and surgeons should be called for help early when a seriously injured child arrives. Often, a pediatrician's help is also invaluable for vascular access and drug dose calculations, especially for preschool children.
Getting the weight right is critical.
Absolutely. In terms of specifics of pediatric trauma, for the airway, if there's suspected spinal injury, a jaw thrust maneuver is used to open the airway, not head tilt chin lift, to protect the spine. Children are prone to swallowing air, especially when crying or distressed, which can lead to massive gastric dilation, their stomachs filling with air. This can decrease blood pressure by pressing on blood vessels and increase the risk of aspiration, where stomach contents enter the lungs. Thus, orogastric, mouth to stomach, or nasogastric, nose to stomach, tubes are often inserted to decompress the stomach.
Air swallowing. Didn't think of that.
It's a big issue. For circulation, hypotension or low blood pressure is a late sign of hypovolemia in children, meaning shock is already advanced when it appears. This is a critical distinction from adults. Early signs of hypovolemia include tachycardia, fast heart rate, tachypnoea, rapid breathing, agitation, lethargy, and pale, cold skin with decreased capillary refill time, best elicited by pressing on the sternum. Gaining venous access quickly is vital. If IV attempts fail quickly, for example within 90 seconds, intraosseous IO access, where a needle is inserted into the bone marrow, is a rapid, easy, and reliable alternative for giving fluids and medications.
IO access,
Yeah.
straight into the bone.
Yes, for rapid access when veins are hard to find. For major hemorrhage, it's generally better to replace lost blood with blood rather than large amounts of IV crystalloids. If blood products aren't immediately available, warmed 0.9% saline, 10 milliliters IV, can be given as a temporary measure.
Blood for blood loss. Makes sense. What about scans?
When it comes to imaging, a whole body CT scan is the quickest way to determine the nature and extent of major injuries. But this must be balanced against the relatively large dose of radiation in a young, developing person. The team leader will aim to target CT scans to minimize radiation exposure, focusing only on areas of suspected injury rather than a blanket scan. X-rays still play a role in certain situations.
Balancing speed with radiation risk.
Always. Finally, parents' needs are paramount. A member of staff should be allocated to interact with them, providing updates and emotional support. Parents should also be informed about the possibility of the child developing post-traumatic stress disorder, PTSD, after a traumatic event. Briefing parents about possible symptoms like sleep disturbance, nightmares, difficulty concentrating, and irritability, and advising them to contact the child's GP if symptoms persist beyond 1 month is important for long-term psychological well-being of the entire family.
Looking after the whole family's well-being. And when it comes to bones, especially in growing children, fractures and epiphyseal injuries are handled very differently than in adults. The phrase, "children are not little adults," truly applies to orthopedics as well.
It absolutely does. The unique anatomy of a child's growing skeleton means that injuries, especially fractures, are profoundly different from adults. We categorize growth plate injuries using the Salter-Harris classification, which outlines 5 types of injuries to the epiphyses, the growth plates at the end of long bones, adjacent to the joint surface. These growth plates are crucial for bone growth.
Salter-Harris, I've heard of that.
Yeah.
Can you briefly explain the types?
Sure. Type I involves the epiphysis separating or slipping on the metaphysis, the shaft of the bone. Type 2 is the most common, where a small piece of metaphysis separates with the epiphysis. Type 3 is a vertical fracture through the epiphysis that also extends through the epiphyseal plate. Type 4 sees a fracture passing from the articular surface, the joint surface, through the epiphyseal plate into the metaphysis. And finally, Type V is a crush injury to the epiphyseal plate, which is notoriously difficult to diagnose on initial X-ray as there might be no visible break.
And why does this classification matter so much?
The implications for these classifications are significant for limb shortening and deformity, as premature fusion of a growth plate can occur, affecting the child's final limb length. The risk of long-term growth problems correlates with the injury mechanism and force. Type I and II injuries, especially if undisplaced, have a low risk of future growth problems, while Type 3 has a moderate risk, and Type 4 and V have the highest risk. Accurate reduction, sometimes with internal fixation, is crucial for Types 3 and 4 to avert problems. Type I and V may not even be apparent on the initial X-ray. For example, undisplaced Type I fractures often affect the distal tibia and fibula, presenting with tenderness around the growth plate, and are treated simply with casts.
So some growth plate injuries are hard to spot but have big consequences.
Precisely. This leads to another important point. Ligament injuries are less common than fractures in children. This is because in children, their ligaments are often stronger than the adjacent bone or growth plates. So, forces that would cause a ligamentous sprain in an adult are more likely to result in a fracture or epiphyseal injury in a child. For example, an injury causing an anterior cruciate ligament, ACL rupture in an adult, might cause avulsion or tearing away of its tibial attachment in a child.
Ligaments stronger than bone.
It's true in growing kids. Radiological interpretation in children presents its own significant challenges. The presence of various ossification centers, which are areas where cartilage is turning into bone, and accessory ossicles, which are extra small bones, can be mistaken for fractures, making accurate diagnosis complex. For instance, the olecranon epiphysis at the elbow or a bipartite patella, a kneecap that haven't fully fused, can appear similar to a fracture. For this reason, most EDs have a policy where all X-rays are reported by a specialist within 24 hours. Any missed abnormalities are returned to senior staff for appropriate action. If there's doubt about an X-ray, obtaining a second opinion from a senior colleague or radiologist is encouraged rather than routinely X-raying the uninjured side to avoid unnecessary radiation exposure. This emphasizes the need for specialized expertise in pediatric imaging.
Right, reading kids' x-rays is a specialty in itself. Okay, let's broaden out again. The ED isn't a silo. It's constantly interacting with other parts of the healthcare system and even external agencies. This coordination is vital not just for patient safety, but also for legal and societal justice.
You're absolutely right. The ED operates within a complex web of external liaisons, which often extends beyond typical medical interactions. For example, reporting deaths to the coroner or procurator fiscal is a frequent and crucial interaction. Many deaths occurring in or in transit to the ED are sudden or unexpected or follow trauma, and the exact cause of death is seldom immediately apparent. Therefore, clinicians must never be tempted to sign death certificates in these cases. Instead, all such deaths must be reported to the coroner or procurator fiscal in Scotland for further investigation to determine the cause and circumstances, ensuring legal and public accountability.
Never sign the death certificate if it's sudden or unexplained in the ED.
Never. Police statements are another area requiring careful management. Clinicians should never provide information to the police without the patient's explicit consent unless there's a specific legal exemption, such as a court order. When a statement is required, clinicians should write it themselves, ensuring it's brief, factual, and avoids hearsay, conjecture, or personal opinion on the likely outcome. Injuries should be listed using both medical and non-medical language, explaining terminology as necessary, and investigations and treatment provided must be accurately detailed. It's advisable to have a consultant review the statement and always keep a copy for your records, along with the ED notes in case you are called to court. This protects both the patient's privacy and the clinician's professional integrity.
Protects the patient, protects the doctor. What about major incidents? Mass casualties.
Finally, managing major incidents, mass casualty events involves extensive external coordination. In such scenarios, relatives and friends of casualties are directed to a separate area, managed by social workers and chaplaincy staff, and kept informed as much and as soon as possible. It is critical that they are not allowed into the ED itself to prevent further chaos, protect patient privacy, and allow staff to focus on critical care. Similarly, journalists and television crews who arrive rapidly after major incidents are kept out of the ED and directed to a pre-arranged room to be briefed by a press officer and senior staff. This structured approach ensures that the ED can focus on patient care during these overwhelming events, while external communication is handled in a controlled manner.
Keeping the ED focused on patients during a crisis. Makes sense. Okay, shifting gears slightly. In today's world, infectious diseases are a constant consideration. How does the ED protect its staff and the wider community, both from common threats and more unusual exposures like various types of poisoning?
That's a critical aspect of daily ED operations, especially with increasing global travel. The essential need to ask about imported diseases is paramount. Clinicians must always ask patients about recent travel, especially within 6 weeks before symptom onset, to identify conditions like malaria, typhoid, or viral hemorrhagic fever such as Lassa fever. This travel history can be a crucial diagnostic clue for potentially rare but severe conditions that might not be commonly seen domestically.
Travel history is key for unusual infections.
Always. Regarding HIV and ED staff safety, the emphasis is on treating every patient as high risk, due to the potential for unknown HIV status and other bloodborne pathogens. This means strict adherence to standard precautions, comprehensive infection control, and prevention measures, including hand hygiene, use of personal protective equipment like gloves and gowns, and safe injection practices for all patients, regardless of their known health status. Needle stick injuries pose a specific risk to staff, but the risk of acquiring HIV can be significantly reduced by post-exposure prophylaxis, PEP, if administered promptly, usually within hours of exposure. Pregnant staff are advised not to treat patients with AIDS due to concerns about specific viral exposures like CMV and herpes simplex virus, which can pose risks to the unborn child.
Standard precautions for everyone. Okay, what about poisonings? The ED must see a lot of that.
They do. The ED also frequently deals with a variety of poisoning examples, each with its own clinical features and specific management principles. For instance, in opioid poisoning, the classic triad of symptoms is coma, a significantly decreased respiratory rate, and pinpoint pupils. The antidote is naloxone, which can be given intravenously, intramuscularly, IM, or intranasally for rapid absorption. Crucially, naloxone has a much shorter duration of action than most opioids, meaning the coma and respiratory depression often recur when it wears off, necessitating repeat doses or a continuous infusion. If a patient is determined to leave and is at risk of recurring respiratory depression, legal frameworks like the Mental Capacity Act can be considered to ensure they stay for observation if it's in their best interest and they lack the capacity to make that decision for themselves due to intoxication.
Naloxone works but wears off fast. Got it. What else is common? Aspirin.
Yes. For salicylate poisoning, common from aspirin overdose, patients typically present with vomiting, ringing in the ears, tinnitus, deafness, rapid breathing, hyperventilation, sweating, and a fast heart rate, tachycardia. In severe cases, ECG changes like increased PR interval and QRS duration can occur, which help confirm the diagnosis and indicate heart conduction issues.
Alcohol must be incredibly common, too.
Oh, yes. Alcohol intoxication is incredibly common in the ED, but it's important to remember the critical impact it can have on both patients and staff. The handbook notes that tired doctors make mistakes, and impaired judgment can result from staying out all night, just as it can for patients who are intoxicated. The fatal dose of ethanol alone is around 300–500 milliliters of pure alcohol. While the UK legal driving limit is 80 milligdl, clearance rates vary enormously between individuals, with typical values of 10–20 milligdl HR, though chronic alcoholics may have higher rates. This highlights the variable and often prolonged effects of alcohol, making precise prediction difficult.
And things kids might swallow, like batteries.
Exactly. Button batteries, especially when ingested by children, can cause significant damage due to their corrosive potential, particularly if lodged in the esophagus or nose. They can quickly cause severe chemical burns. Urgent ENT, ear, nose, and throat referral is necessary for nasal button batteries, and esophageal ones are even more critical.
Button batteries are a real emergency.
A very serious one. Finally, chemical incidents demand a very cautious approach. Clinicians are strictly warned. Do not approach a chemical incident until declared safe by the fire service. Lorries carrying hazardous chemicals display a HASCM board, which is a special sign on the vehicle that tells first responders immediately what's inside and how dangerous it is, guiding everything from evacuation, required personal protective equipment, PPE, firefighting measures, and drainage information. The core principle for patients is decontamination to remove any contaminating substance and minimize absorption into the body, especially via the mouth, nose, and wounds. However, it's critical to note that life-threatening injuries always take precedence over decontamination. If a patient has immediate life threats, they are managed in the resuscitation room even if contaminated, with staff taking precautions. Everything potentially contaminated must be collected, labeled, and kept in a designated decontamination room for radiation testing, and all samples specially labeled with radiation risk information for laboratories. What unites all these varied scenarios, from a simple aspirin overdose to a chemical spill, is the ED's systematic approach to toxicology and safety, ensuring the team is prepared for the unexpected.
Life threats first, then decontamination. Okay, so we've navigated the immediate life-saving interventions and the complex human dynamics of the ED. It's clear that it's a place of organized chaos where highly skilled professionals navigate immense pressure, complex medical scenarios, and profound human interactions daily. We've seen the importance of adherence to guiding principles, rapid decision-making in critical situations, the nuanced care for diverse patient needs, and the crucial role of meticulous documentation and external collaboration.
Indeed. What truly stands out from this deep dive is the multifaceted expertise required. It's not just about medical knowledge. It's about the ability to synthesize information rapidly, make critical judgments under pressure, and manage complex human and logistical factors simultaneously. The ED is a crucible of human resilience, both for those delivering care and those receiving it. It's a testament to how structure, discipline, and profound empathy converge in moments of crisis.
Next time you hear about an emergency, consider not just the headlines, but the invisible network of rules, the intricate dance of a dedicated team, and the sheer mental fortitude required to provide urgent care. What does this deep dive into emergency medicine reveal about the fundamental human capacity for resilience, both in those who give and those who receive care? We hope this deep dive into the Oxford Handbook of Emergency Medicine has provided you with a new appreciation for this vital field. We encourage you to consider how understanding these principles might impact your own approach to unexpected situations, or simply deepen your appreciation for the demanding field of emergency medicine.